Hi, everyone. Welcome back. I am Dr. Samantha, the maternity mentor. I am a board certified psychiatric nurse practitioner, and we are here for another one of our live Q&A sessions that we have every Monday at 9 p.m. Eastern Standard Time, fingers crossed. We've been a little bit absent for the last couple of weeks because we keep trying to get on, and then we have been having some technical issues. So our hope is that we are going to be on tonight and be able to stay on tonight. We've done a lot of work on our side in our home to try to make this possible. So if you guys have any questions, please feel free to put them into the chat. I'm going to try to get through a lot of questions that we have from the previous weeks where you guys had submitted a whole bunch of questions. And so hopefully we're going to get through all of this. If you see me looking off to sides, my producer and my husband are to that side. And then I have my phone on this side because I am trying to keep track of whether I actually stay live. So if I look a little weird tonight, that's why. So hi, Andrea. Welcome. I am going to go ahead and get started, and then you guys can start popping in questions. I'm going to start with questions that I know were not answered before, but then I will circle back to some of the questions that I am not sure whether they actually got to a live broadcast or not. So I had a question on my antibiotic video, and I think this is a good way to open up. And this question was, why did my doctor give me Bactrim? I'm not feeling well about it. It's literally giving me anxiety to take something that's not recommended. So I think that this is a really good way to start out. Antibiotics are a really important part of a healthy pregnancy if you have a bacterial infection. So antibiotics treat bacterial infections. They do not treat viruses. They do not treat yeast. They do not treat anything else. So the first step is to make sure that if you're being given an antibiotic, that it's for a bacterial infection. Now, the most common reason why we use Bactrim in general is for a urinary tract infection. Urinary tract infections are extremely prevalent during pregnancy. And in fact, urinary tract infections are one of the top reasons why somebody will have preterm birth or like a miscarriage type of deal, because what happens is the infection causes uterine irritability, which causes some of these contractions and then leads that way. So we need to treat our urinary tract infections very seriously, and we treat them with antibiotics. Bactrim is a common antibiotic that's used in general, but not in pregnancy. So this viewer is correct in having some anxiety related to it because we don't recommend Bactrim. Now, part of the reason why we don't recommend Bactrim is that Bactrim can actually inhibit folic acid production. Folic acid is extremely important for a healthy pregnancy. This is what helps to prevent neural tube defects. Neural tube defects are defects of the brain or spinal column. So it's how it's formed when the baby is in the first trimester. And if you don't have proper folic acid, then that can actually lead to some of these birth defects. That's why in my practice, I recommend women of childbearing age. So from age 15 all the way to 45, if you're within that age group, you should be taking a prenatal vitamin, even if you are using birth control, even if you are not planning to get pregnant. Because if something was to happen, you've got the right amount of nutrients meant to sustain a healthy pregnancy on board. Additionally, if you're a woman of childbearing age and these are vitamins intended to make your body healthy for a pregnancy, they kind of make you healthy in general. And that's why a lot of women will say their hair gets better, their skin gets better, and all this other stuff. Prenatal vitamins are really good. It also provides you with the folic acid that you need. But if you're taking Bactrim, that can interfere a little bit. So that's why they don't recommend that you take Bactrim even leading up into the first trimester. Additionally, there were some animal studies that showed an increased risk of cleft palate. Cleft palate is where the palate, the roof of the mouth, is open. So do we recommend it? No. Now, these are all risks. So a lot of people become pregnant and they don't realize that they're pregnant when they take some medications. So I try to tell my patients, when I am seeing patients for the first time of childbearing age, one of my standard questions, are you using birth control? What birth control are you using? And it's really important to understand that, because then you make medication decisions based off of that. Every single medication that's being put into your body, if you're of childbearing age, you need to ask them, is this safe for pregnancy? A lot of times women are being given medications that are not safe for pregnancy. And even though they may not be actively trying to get pregnant, they don't realize that that medication could be an issue. A great example, and I was actually talking to a patient today, what a lot of women don't realize is this. If you are taking a birth control pill and you get a viral stomach infection that causes a lot of diarrhea, you need to assume that your birth control pill is ineffective for the rest of the month, and you need to use backup protection if you don't want to get pregnant. A lot of people don't realize that. But diarrhea alone, if you think about it, the GI tract, the intestines, they're moving so fast that your body doesn't have a chance to absorb the birth control. So you want to make sure that you are protecting yourself, okay? And so then when you're talking about some of these other medications, if somebody's going to give you a medication, you want to know if it's safe. There are a lot of other medications that could be used. Now, if you have taken a medication that's unsafe, it does not mean a guaranteed risk to the baby. It simply means that you might need a little bit of extra monitoring, and you might need to go to a maternal fetal medicine specialist. These are the doctors that specialize in high-risk medications. Very often in my practice, when I'm getting a patient, I work now in psychiatry. I was, in the hospital working in maternity and stuff before this, but I do women's health psychiatry. So when I'm getting women, oftentimes when I'm getting them pregnant and they've already been on meds that were like, I wish you weren't on that when you got pregnant. As I titrate them off, we all also say to them, I want you to get in with a maternal fetal medicine specialist and make sure that everything's okay with the pregnancy. So that's what I would do with that. So it looks like I am still active, which is good. Okay, Andrea, I got my second cycle back after my abortion, and it's been 26 days apart. Is that a good sign so far? Yes, that is a very good sign. I would keep tracking your cycle, because it might get a little bit shorter together or it might get a little bit further apart, but 26 days apart is pretty good. When somebody's tracking a menstrual cycle, and Andrea, you may know this, but for anybody who may or may not know this, your cycle starts from the first day you bleed to the first day you bleed, and that is the 26 days. It's not from the day you end to the first day. That's not how you count it. First day to first day. And it's important because then you can start to predict when you are ovulating. The more regular you get, the more likely you are to be able to predict when you are ovulating. There's other reasons to track your cycle when you are pregnant, or when you're trying to get pregnant, I should say, because there are certain medications that you shouldn't take when you're trying to conceive, but could be taken in the beginning. And an example of that would be an ADHD stimulant, not recommended for pregnancy, but could be taken the first 2 weeks out of every month. Andrea, make sure that you're drinking plenty of fluid. The more that you drink within reason, make sure there's some electrolytes in there, but plenty of water. But the more you drink, the more your tissue gets hydrated. Hydration is very important for blood flow. The uterus needs a lot of blood flow to sustain a pregnancy. And then prenatal vitamin. Make sure you guys are taking a prenatal vitamin. So I hope that helps, Andrea. One of my regular viewers, Jennifer, who got to see me eating popcorn last night when I was doing a impromptu live to make sure that the connection was going to work. So hi, Jennifer, if you're on. She had sent a question a while back that said, I bought a jellyfish projector and turned it on, but my baby started crying. Is this normal? So it can be very normal. Babies are just like us. So a lot of people, when we hear about babies, we hear different things. Like, I feel like people try to treat babies differently somehow because they're a newborn. Your baby from like the jump is a mini adult human being. Okay. And that's really how you should look at them. When we talk about the colicky stage, that around 6 weeks to 12 weeks when babies are crying at the end of the day, A lot of people attribute that to food. They'll say colic, and then sometimes people blame formula and all this other stuff. But breastfed babies have that same thing. Babies who really don't ever seem to have stomach issues have that same thing. Like, we see babies crying at the same time. There's a lot of research being done now that says that those babies are actually getting migraines. So the theory behind it is, if you think about it, up until 6 weeks, babies sleep all the time. But around 6 weeks of age, the baby starts to be more aware and more awake. And as that progresses, everything they're experiencing is new. Smells, sights, sounds, everything, texture, everything they're experiencing is new. Imagine if from the moment you woke up until 5 o'clock in the afternoon, every sensation that you were exposed to was brand new. The sensory overload could just be like crazy. And so that can cause babies to be very fussy, because what they think is happening is they're getting a headache. And if you think about it, that colicky kind of period ends around 12 weeks, when these babies have now been exposed to a lot of this stuff over and over. So they're desensitized. They're desensitized to the TV or the dog or their sleeper or whatever. And so then those headaches start to calm back down. When it comes to projector, depending on how you did it, if you were in a very dark room and then all of a sudden it went bright, think about it like a firecracker. How many of us are outside to watch like 4th of July fireworks, and it's dark and it's kind of quiet because everybody knows it's about to start, and then boom, it happens. Sound and light like an explosion. That could have actually been what it was like for the baby, which is why the baby may have become overstimulated and startled and didn't like it. I would suggest for something like that specifically that you might want to retrial it, but have it turned on and enter the room with it on. That way it might be an easier transition. But just remember, with your babies, they're just like us. So they are not always going to prefer certain things, and certain babies are a little bit more startled than others, and that's okay. That's very normal, because we're all just different human beings. Okay, good, Andrea. I'm glad that you're going to start doing that. It's very, very, very important. Okay, so let's do some drying up milk questions. So I had the first question was, I'm about to stop breastfeeding. My daughter is 3, turning 4 in a week. She loves breastfeeding for both the milk and the comfort it gives her. Would it work if I breastfed only at night for the first week, then every other night for the second week, then completely stop by the third week? I'm not sure how to go about doing this, but she gets very emotional and I tend to give in. So congratulations for breastfeeding that long. That's very hard. Breastfeeding is like amazing, but formula feeding is also amazing for anybody who does that. I'm a lactation consultant, so I'm obviously very supportive of breastfeeding, but I am extremely supportive of formula feeding. It is very hard. And what usually happens when you get to that toddler stage is mom is ready to stop long before your child is ready to stop. There's a bond there. It's comforting, etc. The nice thing is your child is 3 going on 4. So there is a great trick that I like to use, and it really does work. So what you're going to do is, if you're only breastfeeding at night, that makes it easier. If you aren't only breastfeeding at night, get to only breastfeeding at night. Once that happens, you're going to do the following. Before it's time for bed, you're going to sneak into the bathroom and you're going to put Band-Aids over your boobs. You're going to put them over the nipples. And then when it's time to breastfeed, have something to drink for your child. You're going to pick your child up. If you rock them in the rocking chair, however you normally hold your child, you're going to hold your child. And when she wants to breastfeed, you're going to go, I am so sorry. Look, mommy has a boo-boo. Mommy has boo-boos on both sides. I'm so sorry. I can't do it. A 3-year-old absolutely knows what a boo-boo is and absolutely knows what a Band-Aid is. And they see a Band-Aid because they've had a Band-Aid, and they get the two together. They understand that there's something there that hurts, and so you can't do anything. And you keep doing that. And then you reinforce, you're a big girl now, so let's drink some milk out of a bottle. Let's drink some milk out of a cup, however you want to do it. You continue to hold her. So that comfort part, you still give the embrace, the warmth, the love, But what you're simply saying is, we can't do this one thing. I've got boo-boos. And you keep that up. And eventually she will probably stop asking. But it's a very gentle way to say no without that whole strict, like, dude, we're not doing this anymore. Now, to be clear, you can say, dude, we're not doing this anymore. Like, your child is not going to be psychologically scarred if you say no. That's called setting a limit. But because of the closeness that breastfeeding does have, sometimes emotionally, it is a little bit of an easier transition to do the boo-boo thing. And the reason why is just, frankly, it is really, really hard to stay strong for that. So that's what I usually recommend. Andrea, does breast size affect milk production? Absolutely not. Breast size does not affect milk production. Usually you'll have two different size breasts. Oftentimes it is not the larger breast that makes more milk. So that's very much, it's variable. I can tell you guys that I personally took care of a woman once, really, really teeny, tiny woman. So she had very small breasts. The one breast was like a very small A cup, like a really tiny, round, regular breast. The other side, and this is very common for a lot of women, that their one side really does not grow the same way as the other. So her other side was practically flat, like practically as flat as a piece of paper. I kid you not, the first time I worked with her, she got 4 ounces of milk out of what looked like a flat piece of paper. And the other side, the side that looked like a little A cup, barely produced a half an ounce. So breast size does not matter. What usually actually matters is the number of ducts and that are available there and how well that breast has been stimulated. And so milk ducts, just so you guys know, they're variable. They are not even. It does not matter the size. Generally, a larger breast will have more, but that is not a hard, fast rule. And this is why it's so important that when women are having breast augmentation or breast lifts or breast reduction, that they're actually educated properly, because your breast, the breast surgeon cannot tell you how many breast ducts are in there. They can't see them. They're like basically practically microscopic. So they can't really save those ducts. There's no sparing surgery. You have to hope that you have enough ducts and not enough of them are cut and all this other stuff. And so you really can't tell just based on looking what's actually going to happen there. So yeah, it was a very interesting case. It was, she was a really nice patient. I liked her a lot. So same video, drying up milk. I had this question. My son is 1 year and 9 months old. I stopped breastfeeding him 3 days old. My breasts are in a lot of pain. What can I do? So it's basically what is going on is this. So, and I had another one, actually, I just want to make sure this is basically the same type of deal. I stopped breastfeeding my son 3 days ago. I did a full body steam treatment, and now my breasts are becoming very big and painful. They're getting bigger day by day. What can I do? Please help. Okay. So one of the reasons why that steam treatment probably didn't work is when you're trying to dry up milk, you want to go for cold, okay? So when you put warmth on your breast, you're stimulating blood flow to the breast. The more blood flow that's there, the easier it is for your body to make milk. So it's saying, please make more milk, right? So instead, you want cold because cold kind of shrinks things up. So a full body steam, kind of like if you were in a shower, is going to stimulate blood flow to the breast and therefore encourage milk production. When you're trying to calm down milk supply, the first thing you want to do is, part of what allows you to make more milk is space. And this is why sometimes larger breasts will make more. So you want to put a little bit of support on the breast. Now, let's be clear. You do not want to bind your breast. That's where you wrap like an ACE bandage around them. That actually puts you at risk for mastitis and plug ducts. You want to wear something more like a sports bra, but a sports bra that's loose enough to have a little bit of give, and you wear it 24 hours a day, 7 days a week until your milk supply is gone. And that's because you want to make sure that there's less space. Then you want to use a lot of cold. The first thing I like to recommend is cabbage leaves. Good old fashioned head of lettuce, cabbage, We have a grocery store right outside our window. That's why I'm looking that way. And so you take that head of cabbage, you wash the leaves, you stick them in the fridge, and then every hour you put on new leaves in your bra. Okay, you just put them on. Cabbage has been used for hundreds of years. The chemicals within cabbage absorb into the breast and they help to reduce your milk supply. Now, a lot of people, I'll never get sponsored by this company, have been reaching for Cabo cream. I've looked into Cabo cream and I'm sure it's a pretty decent product, and I'm not, if that's easier for you to use, I definitely am not knocking it in that respect. I know a lot of patients who've used it and love it. So like, I wouldn't even say it's not necessarily effective. What I don't like about Cabo cream is it does have a lot of other chemicals in it. So, you run the risk of putting other chemicals that could cause eczema or something like that. I don't know how potent it is compared to the real deal thing, right? So, it's hard for me to say that that's really the best thing, but for a lot of people, it's really quick and easy. So there's products like that. Then another thing that you can do is you can actually do peppermint. So peppermint is something that naturally will reduce your milk supply. So I have a lot of women use peppermint tea. You can actually chew real peppermints like Altoids or real peppermint. That will help. And believe it or not, I've had women use peppermint oil deodorant, and that will help to reduce milk supply because there are actually milk ducts all the way up into your armpits for some people. So the peppermint's a really good treatment. And then you can take some of the like antihistamines like Benadryl or Sudafed or something like that to help dry out your milk. But you do want to make sure that you're cleared to use Sudafed. Not everybody can use Sudafed because it can raise your blood pressure and your heart rate. And then for Benadryl, it can make you sleepy. So if it makes you too sleepy, you won't be able to take care of the baby. So definitely like check out the video, which has a lot of stuff. And I do have a video, I believe, on herbs specifically that dry up milk. So check those out. But that's some of the stuff. Those are my big ones. So my next question was on formula feeding. Very big pro formula feeder for sure. And it says, hi, my baby has eczema. Which formula is best for him? Is it okay to give non-fat formula? I've been thinking about trying Bobby's Organic. So great question. Couple different things. So first of all, it's okay to give any baby formula. Okay. If formula is what you need to offer your child, formula is fine. Eczema has been associated with formula, oftentimes cow's milk formula, but you can also get a baby with eczema who's breastfed only, oftentimes because of cow's milk. But what it is that mom's drinking the cow's milk and it goes into the breast milk. So you can have babies with eczema either way. You cannot, let me repeat this, cannot use non-fat formula. I don't even think it exists. It definitely does not exist here in the United States. If you can find a non-fat baby formula, I would run as far away from that as you possibly can. I believe Bobby's is European. Don't quote me on that, but I think it's a European brand. I'm not as up with European formulas. I do have a video on them. I'm pretty sure Bobby's is one of them. I know from, doing that stuff that the European Union would not approve of a fat-free formula. Babies need fat. Fat gets a bad rap in our culture. We need fat, like adults need fat. Healthy fats, healthy cholesterol. We all hear about cholesterol as being bad. There's good cholesterol and there's bad cholesterol. Healthy cholesterol is actually what makes up your cell walls, the walls of the cells of your body. We all need it. Fat helps to control your brain. It does a lot of really good things for you. And babies definitely need fat. So no fat-free for babies. And in fact, once the baby gets to be a year old, I know there's a lot of toddler formulas out there. Just so y'all know, that's a scam. You don't need them. Every pediatric association under the sun will tell you that's a scam. When a baby turns 1 year old, they need to get whole nutrition and they need animal fat for brain growth, okay? And that's where you get that. But even somebody who's vegan can get their child the type of fat that they need for proper brain growth through other means. You talk to your pediatrician and they can give you more. Definitely no fat-free. As far as a kid who's got eczema, you're basically looking for a hypoallergenic formula. So some of the examples of hypoallergenic formulas include Neocate, Nutramigen, and Alimentum. These are all formulas you can find. Sometimes if your baby's like allergies are pretty bad, you can actually talk to the pediatrician and your pediatrician can actually write a prescription and your insurance may cover these because like Alimentum is extremely expensive. The other thing you need to know is that especially as you get further down the line with these hypoallergenic formulas, they smell terrible. They taste awful. So babies may or may not tolerate them. So you want to really work with the pediatrician. Most of the time you kind of go from the standard and you keep working your way down because as you go, they smell and taste worse and they're more and more expensive. So, but definitely no fat-free, guys. No fat-free for babies. Babies need fat. Okay. Anybody who's joining me, welcome, welcome. I'm so glad to be back. I am looking around everywhere. We're trying to make sure we stay alive, but we've done a lot of work on our tech to try to resolve the problem that we've been having. So, I have a question on gestational diabetes. I am almost 36 weeks pregnant with a due date of March 7th. March 7th. Oh my gosh, I'm so old on this one. Okay, well, I'll tell you guys the rest of it. We've had so many tech issues. I had my last ultrasound and there is more fluid around the baby, approximately 8.8. Is that normal? Is that normal or something to worry about? Okay, so what does she even mean? So we have amniotic sac. So you have your baby and your baby's in an amniotic sac. And towards the end, we do a lot of ultrasounds. We especially do that when you have gestational diabetes. One of the biggest risks at the end, and I have a video on gestational diabetes. We worry about stuff like you're at a higher risk for C-section because the baby can get bigger and other things. But we also worry about stillbirth. People with gestational diabetes, even well controlled, are at one of the highest risks for having a stillbirth baby. And that's because the placenta starts to fail and it can fail very suddenly. So we often do non-stress tests and other things, and we will measure the fluid around the baby. So we're measuring pockets of fluid that kind of exist. And so that 8.8, it's 8.8 centimeters of fluid. So it's basically like a line that they found somewhere on an ultrasound image. Okay. So we have certain measurements for how much or how little that we want. 8.8 out of context, this is out of context for me, is not a large amount to me. But we're going to go with the idea that this is large. And so large amounts of fluid is called polyhydramnios, too much fluid. And when there's too much fluid, there are other risks. And one of the biggest risks is if you go into natural labor. So what happens in labor is that with a normal amount of fluid in a normal sized baby, that baby is in like a balloon. But over time, that balloon is filled up and baby's filling most of that up. And the head starts to press on the cervix, right? Sitting very far down. And yes, the amniotic sac, there may be a little tiny bit of amniotic fluid against the baby's head, but basically it's like paper thin. So when your water breaks, a lot of times it's like so easy because that contraction hits and it just breaks and bursts and the water comes out. If you have too much fluid, then instead of the baby's head being down here, the baby's head is floating. So it's up above. Now remember, in that same sac is also the amniotic cord. That's the cord that feeds the baby. It goes from the placenta through into the baby's belly button. That cord can be short or it can be long. There's nothing you do to create that. It just happens. It's random. Well, if the baby's cord is long enough and the baby's head is high enough, what can happen with polyhydramnios is the balloon pops, and instead of the baby's head coming down first, the cord comes down first. If the baby's cord comes down first, then what happens is it can be a medical emergency. The loop comes down, and now every time the baby's head presses, it compresses the cord, and that cuts off the oxygen supply to the baby. So when somebody has polyhydramnios, the biggest thing we are worried about is that actual event happening. Secondary to that, the other thing you need to know about polyhydramnios, the fluid around the baby, the amniotic fluid, is produced by the baby's kidneys. If you have too much fluid, we worry about whether the baby's kidneys are okay or not, or if we have some kind of anomaly. The nice thing is the ultrasounds, we look at the kidneys while you're pregnant, and then usually what will happen is once the baby is born, they'll actually just do another ultrasound of the kidneys to check and make sure everything's okay. All right. Let's keep going. So let's talk about placentas. I have 2 questions on placenta previa. So I have a marginal placenta previa. Should I be worried? In most cases, does it move as the pregnancy progresses? And the second one is, I'm 13 weeks pregnant with a placenta previa and on total bed rest. Should I be worried? So this is a great thing. So for what you have is you have a cervix, okay? And this is what your cervix looks like. For a lot of you guys who are my regulars, you know I like to use this, but this is what your cervix feels like. And in fact, when we first check you when you're in labor, if we say your fingertip, what we mean is our fingertip can kind of go right into that little pocket. And this is what it feels like. This is the texture and everything. So your cervix should be long, thick, and closed. And the mucous membrane is literally in a slit like this because this has to be able to open up to dilate, right? Now, when you're talking about the placenta is a vascular organ. That means it's a whole bunch of blood vessels that attaches to your uterine wall, and that has a whole bunch of blood vessels, and that goes back and forth to feed the baby and transport toxins and other things, right? If that placenta attaches over your cervix like this, that's a complete placenta previa. Okay. Why is this important? Well, when you dilate, you go like that. Remember, I just said this is all blood vessels. So if you dilate with a placenta completely over, what's going to happen is you're going to bleed out, and that becomes a medical emergency for both you and the baby. Okay. So if you have a complete placenta previa, you are going to be having a C-section. It's an auto C-section. There's no way around it. Usually those C-sections will happen between 34 and 37 weeks. Why? Because we can't even let you dilate a centimeter, not even a little tiny bit. The second any of these blood vessels are open, you're bleeding. Okay. So a lot of times also with placenta previa, we're monitoring you. We're making sure that you aren't bleeding. And if you start to bleed, we bring you into the hospital and you're admitted and you stay there sometimes. I've actually taken care of women in the hospital for over 2 months who had placenta previa, because as long as the baby was stable and they weren't bleeding, we tried to keep the baby in as long as possible. But the only way to know if baby was stable was to be monitoring. So that's why placenta previa is such a big deal. So you have complete, you have partial, and you have marginal. Okay. So partial is kind of what it sounds like. It's like half on, half off. Okay. Half on, half off still is a C-section, auto C-section. And then you have marginal, which is right next to it. However, what happens to the uterus over the pregnancy? So when you're first pregnant, your uterus is teeny tiny. It's like small. And that placenta is small. And so, but what happens is your small uterus has to get big to hold the baby. So over the course of the pregnancy, it gets big. Okay. So now as you have it, your placenta, as that uterus wall moves, your placenta can go like this. That's called migration. It's where it moves from the cervix and it moves up. So that is very, very possible. Okay. There's no way to predict if that's going to happen or not. It's just one of those things. It's kind of luck of the draw. We don't 100% know why it happens, but yes, it is possible. Other than that, for somebody on bed rest, you just follow the doctor's instructions on what they want you to do. I have a video on bed rest, guys, that I would totally tell you guys to check out. Bed rest does not look the same for everybody. Andrea, what are breast pumps you recommend for women with D-cup breast size? Okay, so I'm not sponsored. I probably totally should look for sponsorship, but my favorite is Spectra. Amida and Medellas are good pumps, but Spectra is the first product that's over the counter that's believed to be as strong as a hospital grade pump. Ultimately, hospital grade pumps are your best deal. One of the things I would tell you though is a lot of people have coverage through their health insurance to get a free breast pump. You want to get a double breast pump, double, and you want to get electric. So if you don't have Spectra, that's what you're looking for. My backup would be Amida Medela, right? Now, there are new ones. Freeme is one of them. I'm totally blanking on another. LV is another one. These are breast pumps that go into your bra. So there's no tubes, there's no nothing. They're operated by your cell phone, their battery. They're fantastic. They will not get the same amount of milk nor maintain a milk supply as a Spectra, Amida, or Medela. Now, if you're fortunate enough to have the means to have two breast pumps, absolutely. I think the LV and I just forgot the other one, doesn't matter. I think they are amazing pumps and they serve a purpose in certain situations, but ultimately you need a solid breast pump. As far as size, D cup size breast, that doesn't matter. What matters for that is not the pump, but the fact that you need a hands-free pumping bra. So you want to go ahead and start looking for a hands-free pumping bra because that will help support your D cup breast when you're pumping. And it's amazing because then you can do other things with your hands. How does somebody get placenta previa? There's no rhyme or reason. It's really something that we're not 100% sure why it happens. I can tell you that there's 3 placenta conditions called placenta increta, accreta, percreta, which is where the placental tissue actually kind of infiltrates into the side of the uterus wall. That tends to be happen to women who've had uterine surgery. It kind of happens on that uterine scar, and it's not a guarantee. It's very rare, actually. There's some thought that maybe the placenta tends to like migrate or stick to an area of the uterus that's kind of more scarred. And so if somebody's had some uterine surgery where maybe the cervix is a little bit more scarred, that could be, but there's not really any rhyme or reason to a placenta previa. And you could have a previa and get pregnant 20 more times and never have another previa. So there's no, it's just, it happens. So I was just mentioning bed rest, and I have one question on that. I'm started bleeding at 17 weeks. I'm now 23 weeks pregnant, and it's been on and off. The doctor advised me to take Dufastan and stay on bed rest, but I'm still worried. Is there anything else I can do? So this sounds like somebody who's got some second trimester bleeding, which of course is very scary. First trimester, there's a lot of reasons why you might bleed, but in the second trimester, it becomes a lot scarier because there's not as many normal reasons why you could bleed. And usually by that time, bleeding is more linked to there's a complication and we're worried about preterm labor, right? So bed rest is sometimes used. So let's talk about bed rest a little bit. I have a video on it, but it's really important for you guys to understand. Bed rest looks different for everybody. So for starters, bed rest for one person could be you do not get out of bed. You poop and pee in your bed using a bedpan. That could be bed rest for somebody. And for somebody else, bed rest could mean that you have to be in on your couch or in bed 8 hours a day, but the rest of the time you can do what you want. Two very different extremes. So it's important to know exactly what's expected. Some people on bed rest, you know, it's kind of what you imagine. You stay in bed most of the time, but they're allowed to go to the bathroom. Some people on bed rest can go to the bathroom, but they're not allowed to take a shower. Okay. You need to be very clear with your doctor what they're expecting of you with bed rest. Now, why is that important? So bed rest used to be this idea that that was what saved women from preterm labor. And now we know it can actually lead to complications that can lead to preterm labor. So first, it puts you at risk for blood clots. So when you're a pregnant person, your blood clots a little bit better than other people. So you're at higher risk for developing blood clots in your legs that could travel and cause a complication. That's why if you take a long road trip, they tell you to get out of the car every hour and walk around for a few minutes. That's why if you are in an airplane, they tell you to walk the aisles, because you need to move your body in order to make sure your blood is moving and not becoming stagnant and developing a clot. Okay? So when you're on bed rest, then you're just laying around all day, you're at higher risk for blood clots, and that is very dangerous to you and to baby. If you are on bed rest and you truly are in a bed rest where you're not getting out of the bed or the couch, then one of the things you want to find out is what exercises you can do for your legs. A lot of times you can do ankle rolls and leg lifts, and that can help to prevent blood clots. The second thing that you're at risk for is pneumonia. So pneumonia is not just, I got sick with a cold and it turns into pneumonia. If you don't expand your lungs, then what happens is we have fluid in our lungs at all times. Our lungs need to be moist or they would dry up and we wouldn't be able to breathe. Well, some of that fluid can kind of sit in the bases of your lungs. And if you're not moving and expanding and taking deep breaths, which happens when we're walking around, then that fluid can sit there and it can build up bacteria that turns into pneumonia. And if you get pneumonia, that can become a blood infection called sepsis, and then that's life-threatening for you and baby. So you're also at risk for that. So then there's other things you can do for that, like get an incentive spirometer. So it's very important that you figure out what that is. Now, what can you do? Make sure you're eating well. Make sure you're drinking well. You're staying hydrated. And make sure you have something to do. Make sure you have things to bring your mood up, because one of the other biggest risks with bed rest is very much anxiety and depression, and especially depression. So it becomes very long and hard to stay in bed. We think about it, and for like a day or two, it might be nice, but after a while, it really wears on you because it's very isolating. And so it's very important to get a lot of support and help and entertainment. Ask friends and family to come visit you, but only one person per day, so that every day you're hearing new stories or seeing new things. Ask like your manicurist to come to your house and do your manicures, because you're not going to be able to leave, all that good stuff. And then ask your doctor, what are the limits of your bed rest? Some people are allowed to be in a wheelchair, so they're allowed to go, say, to the mall and sit down in a wheelchair and be, wheeled around. It just depends. For those of you who are joining me, hi, please feel free to put your questions into the chat. I'm going to keep going with some of the questions that I got. So we had a whole bunch of questions on urinary tract infections. As I said at the beginning of tonight, urinary tract infections are one of the leading infections that can lead to preterm labor, amongst other things. So we had, can I take nitrofurantoin at 9 weeks pregnant? And then I had a UTI and my doctor recommended fosfomycin. Is it safe to take during pregnancy? I'm currently 29 weeks pregnant. We had a third person who commented, I'm about 37 weeks pregnant. I've been told I have a UTI, but I have no symptoms. I was prescribed nitrofurantoin, but I've declined because I read that it can cause low red blood cells or jaundice in the baby. I've asked to wait for urine culture results before taking anything. I researched and found that amoxicillin is considered safer at 37 weeks. I had a UTI earlier at 20 weeks and was given nitrofurantoin, but it didn't work. I got a yeast infection afterwards and it felt like it never went away. Every time I did a urine test after 20 weeks, they said it was normal. So I love that this person kind of gave us some more information about some experiences, because this is very common. So the side effects that she's talking about for nitrofurantoin, lower red blood cells and increased risk of bilirubin. It is possible, but it is not common. And we see nitrofurantoin used a lot. However, those were small studies, and the studies did show that that could happen. But those are very small studies, so we can't validate it across a larger population. However, what I like about what she's doing is she's doing a risk versus benefit analysis, okay? There are risks and benefits to everything. Nitrofurantoin is safe during pregnancy. It's used very commonly, okay? It is used commonly because it is one of the most effective medications for urinary tract infections. Fosfomycin can also be used, just to answer that other question. But Amoxicillin is also a possibility. Amoxicillin does have more anecdotal use, and so we have a little bit more safety data to it, but it's not always the best for urinary tract infection. Now, one of the things that she opted to do was wait for the urine culture. So what is she doing with that? So urine culture, you take the urine and you look at it for bacteria. That's the first part. And they see the bacteria, they say, oh, you have a urinary tract infection. But then they take that urine and they spread it across cultures to grow the bacteria. And then they basically almost like put a line of each different type of antibiotic and they see which one kills this bacteria the best. That's the one that you should use. Now, if you're very symptomatic and very sick, they're going to start with a broad spectrum antibiotic like nitrofurantoin or amoxicillin. They want to get you started on something, but then depending on what the culture says, they might switch you to a different antibiotic that might work better. In her case, with no symptoms, what she's saying is, I want to wait and know what the culture says. One of the things is we've been struggling with is that there is a lot of antibacterial resistance right now. There's actually a new antibiotic that's been brought out first time in like 40 or 50 years for treatment resistant urinary tract infections. Hasn't been used in pregnant women yet, so I don't think we'll be seeing it in pregnant women, but we'll be seeing it in others. And that's because this is such a huge issue. So I have been finding more and more asymptomatic urinary tract infections, even in my practice. I will order urinalysis on my patients for a variety of reasons, and we're finding bacteria. So it is very under-recognized. And basically, the thing that needs to happen is a risk versus benefit. Is it more beneficial for you to go ahead and get treated even though you're asymptomatic to prevent you from getting like a kidney infection or a sepsis, or is it better to watch and wait? So what I will tell you guys also about urinary tract infections, I am very homeopathic. I love homeopathic treatments, but I'm going to tell you right now, cranberry juice does not treat a urinary tract infection. It can help prevent a urinary tract infection because what happens is it acidifies the urine, which helps to prevent the bacteria from being able to grow a lot. Also, D-mannose is another one that's commonly used when you're not pregnant. That does not treat a urinary tract infection, but it can like make it harder for the bacteria to stick to the bladder walls, which is why it's often used. I don't recommend D-mannose during pregnancy because it's a supplement and these aren't regulated by the FDA and there's no evidence of their safety or non-safety. Cranberry juice, if you get real true blue cranberry juice that's in a glass container and does not have added sugar, it's okay. But if you have diabetes, even no sugar cranberry juice is going to be a little bit of sugar. Why do you get a glass bottle cranberry juice, guys? Because cranberry is highly acidic. That's how it works. And that acid, in my opinion, eats away at the plastic, and then you're getting some of that plastic chemical in your cranberry juice. Hi, Tess. Acupuncture for inducing labor. Do you have any content on this? No, I don't, and I need one. So I'm going to be adding this to my list, but I can tell you a little bit about it. So acupuncture is amazing. There are acupuncturists that can help with fertility. There are acupuncturists that can help to induce labor. This is a real deal thing, but what you need is somebody who's certified in this. There are actual specialty certification courses that acupuncturists can take to help learn this. The trick to this is if you are getting acupuncture during a pregnancy, you actually need to make sure you're with somebody who's certified. Because let's say you're like 24 weeks pregnant and you're getting acupuncture for back pain, which is safe if you're working with somebody who knows what they're doing. If they hit the wrong spot with their acupuncture, then they could actually induce labor. I can tell you personally, when I was pregnant with my daughter, I tried acupuncture amongst many other things to try to have her, and it totally did not work, but it was actually very relaxing. But I tried it, oh my God, I'm so old, 22 years ago, because even back then, in the good old days, that we knew that acupuncture could be used for that. But again, what I can't stress enough is the importance of getting with somebody who's certified, because you can have a pressure point. These are just examples, by the way. You could have a pressure point right here that would help with back pain, and right here who could trigger labor. Like they can be that close on different parts of the body. And there are multiple places that you can actually like trigger labor. And oftentimes they'll do like multiple spots at the same time. This also goes, just so you guys know, for massage. You need a prenatal certified massage therapist. You should not go to a regular massage therapist. They can induce labor, and chiropractors can induce labor. So you want to make sure that you know that. Additionally, for some of these treatments, they will use essential oils. I love essential oils. I think they serve a very good purpose for health, for the energies of your body. They're very good from that scent perspective. However, essential oils, I will not tell my patients what to use on their skin, because you need to be certified in essential oils. They are that tricky. They can cause serious issues, including miscarriage. And so you need to know exactly what you are doing before you use them. So when you're going in to get a massage or to get, say, acupuncture or something like that, you want to tell them not to use essential oils on you, because if they aren't sure what they're using, that could be a very big deal. So what could you use? Because, if you're getting a massage, oil on the skin is nice. Organic coconut oil. Organic coconut oil is completely safe. It's not going to hurt you, and it can work the same way. So, Tess, I will be working on a video for that, because I definitely need to do something on that. Let me go to pelvic pain. I am 5 months pregnant, and I am experiencing a lot of pain in my right pelvic area. Could this be symphysis pubic dysfunction or just normal pelvic pain? So symphysis pubic dysfunction, SPD, is actually where the center of the pelvic bone separates. So if you look at the skeleton, like you've got that girdle, and the center of that bone, right, comes together, and there's like this little line. That's like where it separates a little bit. So when you're pregnant, you start to have a hormone called relaxin very early on. And relaxin helps to relax the joints. That's its job. And part of the reason why it does that is so that the pelvis itself can open up to allow for the passage of the baby, right? So that relaxin is what causes women's noses to get bigger during pregnancy, their feet to get bigger, their hands. Like the reason why you see women start to change shape a little bit is because all of the joints are relaxing, all of them. Okay. Now, that's also what gives women that waddle, because that allows the pelvis and the hips to start to relax a little bit and give a little bit of give. And then the baby can settle in. And that's where you get that, right? But with pelvic symphysis pubis, it's in the center usually, and it's like you're dying. Like there are women who have to use walkers because it's so bad. It usually happens post delivery. That right pain, right? That right pain is usually round ligament pain. I lost it for a second. So your uterus is this big floating organ in your belly. So the some of your organs are kind of like just attached to the wall of your abdomen. So like your liver is like basically on the wall of your abdomen. Your heart and your lungs are basically like encased here, and they're getting a lot of support from bones that they're attached to and or the sides of your belly. But your uterus actually floats. It's not actually sitting right against any of your abdomen. And so it's held there by these ligaments. They're called the round ligaments. They kind of like are strings that kind of attach, right? So when you're pregnant, what happens is those ligaments start to get stretched. And sometimes you'll move a little bit or the baby will kick you and you get this sharp pain. So that's usually when you get it, especially on one side or the other, that's usually what it is. But the last thing I'm going to tell you is I saw in your question, right pelvic area pain. You absolutely need to make sure your doctor takes a look at you. Right lower abdomen, where somebody might say pelvis, depending, because I'm not sitting in front of you being able to see where you're pointing, could be your appendix. So you want to go get that checked out. I have a client, I'm a postpartum doula, whose lactation consultant told her she doesn't have enough fat in her breast milk for the baby from just looking at pumped milk. Is this a thing? Yes, it is. And I should do another video on that. But that's a little misleading. Okay. Oh, wait, hold on. Okay, for a second we thought we were not live, and then my producer realized we are live. So we thought for a second we lost it. Okay. So in your breast milk, you have foremilk and hind milk. Okay. So as you're pumping or feeding, the milk that's coming out changes in composition. So each drop that's coming out is a little bit different. The foremilk is higher in sugar and the hind milk is higher in fat. Okay. Once your breast milk supply is established, so the first couple of days, we're always telling women do 10 minutes and 10 minutes, right? The idea is to just get as much stimulation as possible to get the milk supply going. But then once your milk supply is established and we know baby's eating well, it's actually better for the baby to eat on one side for 20 minutes and in 3 hours, the next side for 20 minutes or 25 or whatever it is. The idea with that is that when you have the baby eat on just one side, you're emptying that side completely. You reduce the risk of plug ducts and mastitis. You also allow the baby to get the full complement of both the foremilk and the hind milk. If you make a lot of milk and you do 10 minutes and 10 minutes, those first 10 minutes on each side could be just sugary milk. Some of the symptoms of a baby who's getting a lot of sugary milk can actually be green poop. A lot of these babies will have like a green kind of frothy poop. Their poops will be a little bit thinner. They will not always gain as much weight as fast, and they'll be a little bit fussier because that milk in the front that's very sugary, it can really upset their stomach. So the thing is, I've never seen a mom that's not had the right amount of fat. It's just usually behind. Depending on how long the person is pumping for, if they have a large, robust supply, and so they pump out, say, 4 ounces in a couple minutes, like 10, 15 minutes, they may not be leaving the pump on long enough to really get that hind milk out of there because they may think that they're already empty. One of the biggest issues is for overproducers. They have so much of that foremilk that sometimes they don't get to that back part. And so that can be challenging. If somebody is thought to have a really robust supply, and we think the baby's getting a lot more of the sugary milk than the hind milk, one of the things you can do is pump off for like 1 or 2 minutes to get off a little bit of that sugar milk, and then try to encourage the baby to like latch then. So the baby will hopefully like latch longer and get to that hind milk. We see this sometimes in babies in NICU where they're not gaining weight, so they'll use breast milk fortifier. That is a very controversial thing at best, and it's kind of something like you have to look at like the whole picture to also see. I've heard it in practice that some women may not be getting the right nutrition, but I've never seen that. It's usually that there's just a lot more foremilk and you've got to get some of that off so the baby will get to the hind milk. So I hope that answered that question. Okay. Second trimester bleeding. Is brown better than red? I've had a few beige drops. I'm 15 weeks pregnant with no cramps, just scared. So brown is usually better than red. I have a video on this. Basically, brown is old blood and red is fresh blood. So when you are actively bleeding, it'll be a bright red. And we have a video on this. So when you're seeing brown, it's usually resolving blood. But you don't want to just assume it's brown and no big deal. Any blood, guys, anything at all, you call the doctor, you get examined. You need an ultrasound to look at what's going on, to see what could be the potential cause. Is it a placenta previa? Is it a subchorionic hemorrhage? Is it that you've got some kind of infection? You always want to make sure that you're getting checked out, but brown is usually more reassuring. Speaking of subchorionic hemorrhage, I'm 5 months pregnant and I have a 5-centimeter subchorionic hematoma. I've been using progesterone tablets. Please reply, could this lead to a miscarriage? So subchorionic hemorrhages are basically like a bruise. So what happens is you have this placenta that's all these blood vessels. And if you've ever thought about it, if you've ever banged your hand and gotten that bruise, that like bluish, brown, or blackish like spot underneath, what that is that blood vessels underneath your skin broke. And what you see is a pooling of blood. That's all a subchorionic hemorrhage is. Some of the blood vessels here broke and it created a pooling of blood that we see. Well, if it's close to the edge of the placenta, some of that blood might leak out, which is why we'll see some brown blood or some pink or whatever. Then usually what happens is you call your doctor because you're bleeding. They bring you in, they do an ultrasound, and they find this pooling. Subchorionic hemorrhages often resolve over time. Okay, so just like the bruise. So in the case of my hand, I get a bruise here. Well, my hand's not changing size. So what happens is that bruise, it gets smaller and smaller and smaller because the blood kind of just goes away and reabsorbs, right? But in the case of a subchorionic hemorrhage, the same thing is happening. But in addition, the placenta is going from tiny. So if I have a subchorionic hemorrhage right here, look, that's taking up like 100% of the space. But now if I have a placenta that's this big, that's taking up like what, 10% of the space? So as the placenta gets bigger, that space is always getting smaller, and that also causes it to resolve. So it is possible, but subchorionic hemorrhages do not usually, it's not like this direct correlation. It could be a contributing factor to a miscarriage, but just because you have one does not mean that you will have a miscarriage. I am going on. I have a question on sex. So many people who've checked out my channel, who've been here for the lives, I'm a very big advocate on talking about sex. I talk about sex every day with my clients. Sex is a part of the normal human experience, and it's very important to have good sex. It connects us with our partners. So I have a lot of videos on sex, and one of the things I have now is I have a video series on the best positions to have sex during your pregnancy, right? Because each trimester, as your uterus changes, the weight that's in your body, it changes. And so different positions can actually be more comfortable or less comfortable. And so this person asked, can I do cowgirl during my first trimester, the second month? So cowgirl is basically where you sit away, you're on top and you sit away from your partner. You're facing the other direction. So the answer to this is yes, that is totally fine. To be clear, all of the positions are safe as long as your doctor has not told you that you can't use those positions. But some of these positions, when you go through the different videos, the reason why they're better for that trimester is simply because it could give you better maneuverability. It might be better for supporting the belly. By the time you get to the third trimester, a lot of it is about supporting your belly so that you actually don't put strain on your back, which is causing you to be in pain instead of enjoying yourself. So the answer is really truly that's fine as long as it's not been contraindicated by your doctor. How many weeks pregnant can we begin to express colostrum? I love this question. So the answer is, the cop-out answer is, you need to ask your OB-GYN. Okay. So what I'll tell you is some of the research. There is research starting in Australia that says that if you start pumping once a day at 37 weeks for 10 minutes, twice a day at 38, and 3 times a day at 39 weeks, you can actually start to express colostrum, but it also helps to ripen the cervix because you get a little bit of contractions, and those contractions can help to, help the cervix to start to soften and dilate, right? So a lot of people will start to collect colostrum as early as that time. But let me be clear, 37 weeks for starters is a preterm baby. The reason why we now deliver babies at 39 weeks is anything before 39 is considered preterm because there's some key brain development that has not occurred yet. It actually occurs up to 40 weeks. That brain development is related to suck, swallow coordination, temperature control, and glucose control. So if a baby is born at 37 weeks, these kids oftentimes don't eat well. They are very tough to feed, even with a bottle. A lot of kids get sent to the NICU, the Neonatal Intensive Care Unit, because they can't even use a bottle. And then the glucose control comes because they don't have enough fat on their bones. So then they don't have the reserves. And temperature control is just another part of brain development that's very late in the game. So these kids tend to get cold fast. So we try to keep kids in as much as possible. So if you're at 37 weeks and you're trying to collect colostrum, it doesn't matter whether you're doing manual expression or you're using a pump, you are very likely going to stimulate some contractions. If you're at risk for preterm birth, like if you're already 4 centimeters at 37 weeks, you should probably not be collecting colostrum because you're likely to go into full-blown labor and have a preterm baby. If you had a placenta previa, heck no, you are not going to be collecting colostrum because you are at risk for like causing labor and seriously putting yourself and your baby in danger. So it depends on your situation. I could come up with a million other scenarios where collecting colostrum might not be safe. However, it is a great discussion to have with your OB-GYN, and I would hope that they would let you do it because it is an amazing natural way to start your body getting going. And then, guys, if you're going to collect colostrum, this is the other key. You can go on Amazon or other places like that and get storage containers. You need to make sure you take those containers, you label them. They need to have the date and the time that you collected it and your name, okay? And then you stick those in the freezer, in the very back of your freezer. If you store them properly and they are dated and timed and have your name, the hospital will let you use them for the baby. But if you do not freeze them, if they are not labeled right, if all that stuff is not right, the hospital will not let you use it because they consider breast milk medication. So just make sure you're storing it right so that you can use it for the baby. Okay. I had a couple questions on yeast infections. So, the first question was, I'm 27 weeks pregnant with my second pregnancy. I was prescribed fluconazole. Hold on a second. Am I? Okay, just making sure I'm live. You guys can hear me, right? If somebody can hear me, just put a thumbs up in there while I keep going. I was prescribed, I'm 27 weeks pregnant with my second pregnancy, and I was prescribed fluconazole, 150 milligrams, and a Seshre vaginal tablet. Is it safe for the baby? The second one says, can I use polygynix during my second pregnancy? So let me start with polygynix and the Seshre, I'm hoping I'm saying that right, vaginal tablet. Those are not used here where I'm at in the United States, so I cannot comment on whether those are safe for pregnancy or not. That's not something that I'm familiar with. So what I would tell you is anything you guys are looking for a second opinion on because you're not sure, ask your local pharmacist. Pharmacists, oh, thank you. I appreciate it. Pharmacists, they are the ones that can give you that second opinion when you want to have that risk benefit analysis because they have specialized training in medications in related to pregnancy. So for those two, that's what I would say. Now, fluconazole, 150 milligrams. So fluconazole gets a really bad rep. If you look online, oh my gosh, you're going to hear fluconazole is the worst thing ever. And yet we give it all the time during pregnancy. So I want to be clear. This is a great example of where you need to have a clear conversation with your doctor. Fluconazole is amazing for yeast infections. Yeast infections are an infection that I have seen time and time again cause preterm labor. It is so important that we treat those infections. And fluconazole, one tablet, 150 milligrams, can knock it out. So this is why it's given. Fast, quick, effective. Fluconazole at high doses can be hazardous. I will be clear. At a high dose, you absolutely do not want to take it. So what is a high dose? 400 milligrams to 800 milligrams. That is a high dose, hazardous, do not do during pregnancy. But doses under 200 milligrams are considered usually safe. It is a risk benefit analysis. Like you have to talk to your doctor and make sure this is the right thing. But most of the time, the risk of having an untreated yeast infection far outweighs taking a one-time dose of 150 milligrams of fluconazole. Those 400 to 800 milligram doses, those are being used in people with treatment-resistant infections, fungal infections that are not seen in pregnant women usually. Okay? Ureaplasma. What happens if you get ureaplasma while breastfeeding? My child is almost 2, and I've had this infection for nearly a year. No doctor tested for it until this month, so I finally have answers, but now I'm worried. Should I be concerned for my breastfed child? So ureaplasma is a bacteria that can be found in the uterus and in the vagina, and it can lead to, amongst other things, painful sex. That's oftentimes how it's found, but ureaplasma is something we test for if you show up in the hospital with preterm labor. We're also swabbing the secretions and sending it off. It's treated with antibiotics, so once we know it's ureaplasma, there are certain antibiotics that we use. Can it be passed on to the breastfed child? Yes. However, it is passed not through breast milk, but through your hands. Okay. So you want to make sure you're washing your hands. Okay. And we should be washing our hands, before we breastfed at all. There's actually the risk of giving yourself mastitis if you've got bacteria on your hands and you touch and you have some kind of wound. But it's very rare to be passed on to the breastfed child. That is like so incredibly rare. And ureaplasma is a rare infection on its own. So this is not something that the average person should be like thinking about day in and day out. And the baby would get some kind of symptoms. So if it's been a year, the baby's probably never going to get it. So, okay. Twins. Is it possible to give birth to twins at 39 weeks? Absolutely, yes. You can give birth to twins at 40 weeks. They, generally speaking, try not to let you go past 38 weeks because they're worried about, what it looks like to have twins. But yes, you can go to 39 weeks. The biggest thing I'm going to tell you guys about twins, and I really like to talk about it with my patients because I actually have some patients who've had PTSD from their twin deliveries because of this. Twins are usually delivered in a hospital, not a birthing center, not at home. Generally speaking, they try to get you into a hospital because there's higher risk for complications. If you're in a hospital, most people will labor in a labor room and they deliver in a labor room, but not if you're twins. If you're twins in a hospital, you actually deliver in an operating room. So you will labor until you're 10 centimeters, and then they will bring you into an operating room and you actually deliver your babies vaginally in there. So the reason for this is that once the first baby comes out, assuming they can deliver, because not every baby who's ready to be delivered vaginally gets delivered vaginally, right? Sometimes stuff happens. But assuming that baby comes out, when baby A comes out, baby B, who might have been head down, can flip. All sorts of stuff can happen. Baby B's cord, remember we were talking about the cord earlier with polyhydramnios? Baby B's cord could slip down underneath, and now it's a medical emergency for baby B. So we deliver moms in an operating room so that we're ready to do a C-section should we need one in an emergency. This can be overwhelming because you get wheeled into this operating room. You're in full garb as if you're going to get a surgery. Your partner is in full garb as if you're going to get a surgery. Everybody in that room looks like they're ready to do a surgery on you. And there's like 20 people in that room because for a twin delivery, we have 2 whole teams for the babies, one for baby A and one for baby B. That alone can be 8 to 10 people. So you have all these people in this room, and that can be very overwhelming for what ends up being a standard vaginal delivery, because a lot of women will have standard vaginal deliveries. So I just like to say that for anybody who's expecting twins, because they don't always expect that. Wafa, how important is taking baby aspirin for pregnant women above the age of 40? Absolutely, it's hugely important because that can help to prevent some of the complications related to preeclampsia. I have a video on aspirin use, and it's very important to take aspirin. We get a lot of questions on it. Usually you're going to take 81 milligrams, which is baby aspirin. In fact, one of the questions I got was, I was told to take 162 milligrams of aspirin. Is that high? that is what I would consider high. So if somebody's being offered more than 81 milligrams, you want to make sure you understand why, because regular dose aspirin, 325 milligrams, is not safe during pregnancy. I've never seen it used. It's not, there's no literature to say it's safe. But baby aspirin helps to reduce your risk of blood clots. It helps to smooth things out, and it helps when you are having higher blood pressures to prevent it from being too high later on. So yes, we absolutely use it. Is it too late for me to take it? I'm 15 weeks pregnant. Absolutely not, Wafa. Please check out my video. But usually we're not even recommending it until like 12 to 15 weeks. So usually it is a little bit later. If for anybody who wants to be clear, there's no evidence to show that baby aspirin prevents miscarriage. So if you do not have the risk factors associated to preeclampsia, do not just take baby aspirin. You need to take baby aspirin if your doctor has told you to take it. But for example, one of the questions was, my midwife has recommended that I take aspirin just because I'm 36 years old. Does that make sense? And the thing is that unfortunately, once you're above the age of 35, you're considered a geriatric pregnancy. You're an old pregnant lady. And so that puts you at higher risk for preeclampsia. So yes, above the age of 35 is one of the criteria. Then, one of the other questions that sometimes happens is, I have a subchorionic hemorrhage. Remember, that's that little bleed underneath. Should I continue to take the baby aspirin? Most of the time, the answer is yes. We still want you to take the baby aspirin because of the preeclampsia risk. But yeah, Wafa, talk to your doctor first to triple check that there's not something else going on in your pregnancy that might contraindicate it. But yes, you at 40 years old, you absolutely should. You should also be sent to a maternal fetal medicine specialist because you're a geriatric pregnancy. You're not old, but they say we're old. Swelling. So kind of going along the same line of preeclampsia. My legs usually swell, but the swelling goes down over time. However, now that I'm in my third trimester, the pain and the swelling are getting worse. Swelling is a huge warning sign for preeclampsia, guys. Swelling is a big deal, and you definitely need to take it seriously. Yes, there is normal swelling of the legs. But one of the things you can do if you start to swell is weigh yourself every day. If you gain 1 or 2 pounds overnight, that is probably a warning sign that you're about to become preeclamptic. And so it's really, really essential that you keep an eye on it. Also, if you have swelling in your face, that's very common that women will get swelling in their face as a sign of preeclampsia. Some of the warning signs for preeclampsia include headache that doesn't go away with treatment, like a Tylenol doesn't let it go away. You can also get visual changes, and you can get pain in your upper right abdomen. So that, in conjunction with the swelling, are often warning signs. Now, let's say you've just regular leg swelling during pregnancy. Just what would you do for a swollen ankle? If you sprained your ankle and it was swollen, what do? You sit on a couch, you put your feet up. Maybe you'll even ice your legs. You can do that. Those are all safe. And then pregnant women also, because they will have a lot of blood flow that doesn't move as well, they'll use some of those compression stockings to prevent varicose veins and stuff. If you're a pregnant healthcare worker, what main infections should you avoid? What are the main infections we should avoid contact with, even with PPE? The biggest one, I'm just making sure. COVID and flu are not great, but if you get the vaccine, you should be okay. The reason why pregnant women get those vaccines, guys, or it's recommended, is because pregnant women are immunocompromised. Their immune system, your immune system, when you're growing a baby, has to be it has to be tamped down. It has to be calmed down, or it can view the baby as a foreign organism that needs to be attacked. And so it has to be calmed down because your baby has slightly different DNA from you, and that can be viewed as a danger. So the women then become at higher risk for deadlier infections because of that, which is why we recommend the vaccines. But if you have the vaccine and the PPE, you're pretty good. So I'm thinking that tuberculosis and chickenpox are the two. Now, tuberculosis would be very rare for anybody to encounter unless you work in a tuberculosis hospital, but chickenpox, absolutely. Chickenpox is not something you should be exposed to when you're pregnant. It is very deadly for the baby. That is something that you need to avoid, but most hospitals will keep you out of those rooms. However, healthcare workers, one of the things you do need to be careful about is touching medications. So there are a lot of medications that if you touch it with your skin, it can absorb through your skin and it can cause preterm labor and other things. Most of the healthcare systems scan meds, and those scanning systems are starting to put up warnings, but there are medications that actually can be dangerous if you touch them with your skin. A great example is Cervidil, which is used for inductions. That's a great example. If any of that absorbs into your skin, there's a potential for you to be in labor. Doctor did not mention anything, but the midwife said to take it. Yes, the midwife is correct. That doesn't shock me that the midwife's the one who said it. I am almost done, guys. Okay, breastfeeding while pregnant. Can I continue to breastfeed while I'm pregnant? My baby is 9 months old. Absolutely. Unless your doctor tells you there's a contraindication for it, you can absolutely breastfeed while pregnant. It happens all over the world all the time. The biggest thing is you need to actually monitor the older baby and make sure they're still peeing and pooping right. Because no matter what you do, even if a baby is breastfeeding well, the body will sometimes convert breast milk back into colostrum midway through the pregnancy. There's nothing you can do about it. It happens and it doesn't happen. It's random. But if it happens, then the volume is going to be too little for the older baby. So you want to monitor that. So the last thing that I'm going to answer questions on is blood pressure. So I had several questions. So I'm going to tell you what they all are. So I'm 13 weeks pregnant. I went to the hospital and my gynecologist prescribed nifedipine 20 milligrams. Is it safe? I was prescribed propranolol at 34 weeks pregnant for SVT. Is it safe? I am taking metoprolol for mild mitral valve prolapse. I'm 2 months pregnant now. Is it safe? And can I take 5 milligrams of amlodipine? I'm 3 months pregnant. So those were all of the blood pressure meds. Okay. So the blood pressure meds, a lot of them are safe for pregnancy. And they do need to be monitored very carefully. The first one I'm going to start with is amlodipine. Amlodipine is a calcium channel blocker. That's the category of blood pressure medication that it's in. Calcium channel blockers are the least researched with pregnant women. We tend to avoid them during pregnancy because there's just not as much data and there's so many other medications that work well. And so we try to lean into those first. However, they seem to be safe as far as we can tell from a birth defect, perspective, but there is some evidence that they may increase your risk for a low birth weight baby and or a preterm birth. But let me be clear. If a calcium channel blocker is the only medication that works for you, the risk benefit, it's probably better to take the medication than to go off of it. High blood pressure, if left untreated, can be life-threatening for both mom and baby. Second one was metoprolol, and I'm going to actually combine that with the propranolol. Metoprolol, OLOL, and propranolol, OLOL, that ending, that is the category of beta blockers. Beta blockers are extremely common during pregnancy, with the one that we use the most being labetalol. So oftentimes you will see docs lean into labetalol as the one that they use. Now, SVT, supraventricular tachycardia, that is a type of heart rate rhythm where the heart rate will be normal and then it'll spike to 200 and then it's back to normal and then it spikes and then it's back to normal, right? So this is a pattern. It is very common during pregnancy. The reason why we use beta blockers is because it lowers your heart rate, so it can be extremely effective for that. Propranolol is not as good at lowering blood pressure, but it's pretty good at lowering heart rate. So they might have leaned into that one for that particular condition because in SVT, your blood pressure might be normal. So you want to know why they're using what they're using. Metoprolol is milder than labetalol. And so for a mitral valve prolapse, this is where one of the valves of the heart is kind of leaky. It doesn't work right well. they may not want to go for a robust labetalol, and they might use metoprolol. So there's a lot of different reasons why we use the different meds, but generally speaking, the category is safe. Then we had nifedipine, 20 milligrams. Nifedipine is a long-acting, I think it's an ACE, but it doesn't matter. It's a long-acting blood pressure medication. Nifedipine is amazing because guess what? Nifedipine 10 milligrams can help to stop preterm labor. If somebody comes in and they're having preterm contractions, we can actually give nifedipine and it calms down uterine contractions. So nifedipine is a great medication because it lasts for 24 hours at the 20 milligrams and above, and we can use it to prevent preterm labor, but also control heart rate. Blood pressure. And oftentimes we'll actually use nifedipine with labetalol together when we're starting to get a treatment-resistant depression, blood pressure. So that can be used. The final part of this question was, is 130/90 safe during pregnancy? Is this a normal blood pressure? That is absolutely not a normal blood pressure. I am very big on people understanding what the blood pressure guidelines are. Blood pressure is not normal if either number is elevated. So if you're above 120 or you're above 80, you have high blood pressure. This is not something that's commonly talked about, and we dismiss higher blood pressures and say they're fine. 130/90 is not fine. However, once your pregnancy gets to a certain point, if you've been having higher blood pressures like that, we can't bring you back down to 120/80. If your pregnancy has been sustained at 130/90 or above, if I bring you back down to 120/80, your placenta might actually fail and it might be life-threatening for the baby. Once the placenta gets used to higher pressures, if you lower the pressure too much, the placenta doesn't work. So what we have to do once you have high blood pressure during pregnancy, it's this balancing game of trying to keep it low enough to keep you safe, but not too low that it's bad for the baby. That's oftentimes why women will get hospitalized and why we have to monitor them carefully to make sure everybody is safe. And with that, I am done talking. I appreciate all of you guys. Yay! We were able to stay on for the entire time. My name is Dr. Samantha. I am the maternity mentor. I am here, hopefully, every Monday at 9 p.m. Eastern Standard Time to answer your questions live. I am praying that we got our tech issues fixed and that we should be having more of these. Please check out the channel, and I really appreciate all of your support. Bye for now.